Welcome to the best paper session of the meeting. We've been doing this session now for 6 or 7 years, and it's gradually grown into a little larger group each year. And the idea is that we all know that the Journal of Vascular Surgery is our preeminent journal, but there's a lot of other vascular papers relative to our field that are published elsewhere, and this gives us an opportunity to go over a few of these papers and to discuss them. Now, I will admit that we don't have any. I'm supposed to tell you that there are. Everyone will supposed to talk about their disclosures, and that you can get CME credit for this activity. I think as time goes by. So one of the important things to remember is that not only I don't have any disclosures, and we're discussing pretty scientifically rigorous papers. The process for getting here is not scientific at all. It's I review journals, and Dr. Kashyap reviews journals. He's unfortunately not able to be with us today, but he and I get together and discuss which ones we like. So it really pretty much has to do with our personal thoughts about what's on this program, and although we're always willing to take any suggestions anybody might have. The idea is that it's not bad to have controversy, and that some of these things hopefully will have potential to influence practice. The way we select speakers is also not scientific. They are individuals that I believe can think critically and are willing to disagree with things. And they tend to be a mixture of younger and sort of so-called more seasoned speakers. And in the past, I've been very impressed with the quality of the presentations of these individuals, especially by the younger people. And shows that our society is in good shape as time goes by. We try to choose a variety of topics, from epidemiology to aneurysm to medical management, venous disease, so that we can appeal to all aspects of our practices. The journals that we use for the selection process are not any particular ones, but because the papers are thought to have fairly high impact or potential high impact, they tend to come out of the major journals. As you can see, if you look at the impact factors for the medical journals, the big players are JAMA, New England Journal, and Lancet. And a number of the papers will be coming from those journals today. So we're going to start off with some epidemiology papers on smoking and peripheral vascular disease, and then we'll move forward up from that to a little bit of medical management and use of beta blockers, and then and potential medical treatment of aortic aneurysms. And then Dr. Chekhov will tell us about how we should measure abdominal aneurysms as we follow them. Then we'll have a discussion, and then maybe a little bit of time on a few papers that we considered but didn't actually include in the final 10. And then we'll talk about renal artery stenosis and stenting, and then endovascular therapy of dissections, and endovascular therapy of ruptured aneurysms. And then finally, we'll move on to acute venous thrombosis and complete oral treatment of venous thrombosis. So with that, I'd like to get this started, and Dr. Shankar from Rochester is going to come up and talk to us about the impact of a smoking cessation program on a national basis. Thank you.
Thanks, Greg. Good morning. These are my disclosures. So in 1964, a seminal paper by the United States Surgeon General was the first to correlate negative health impacts of cigarette use and tobacco, which stimulated a significant public-private partnership towards anti-smoking campaign. There were studies that had been done by the authors that looked at lung cancer-related deaths, and about 800,000 lung cancer deaths were potentially avoided during a 25-year period. The goal of the authors for this study was to expand that to all smoking-related mortality. The methods they used is they looked at actual smoking-related rates from 1964 to 2012, approximately a 50-year period, and then they compared the estimated mortality that actually happened to a mortality that was estimated if no cigarette control had been initiated. They derived the cigarette smoking history from the National Health Interview Surveys. Primary outcome measures that were looked at included number of premature deaths avoided and the corollary number of years of life saved. And then a secondary outcome measure looking at longevity of life as a result of smoking cessation looked at the change in life expectancy after the age of 40 for this same population. What the authors found was that from 1964 to 2012, there were approximately 17.7 million deaths that were related to cigarette use. And of this, they estimated that approximately 8 million deaths were avoided due to the initiation of cigarette smoking cessation. This effect was more impactful in the male population of 5.3 million with 2.7 million women. What these 8 million deaths correlated to was approximately 157 million years of life saved, which was approximately 19 to 20 years per beneficiary or per individual who stopped smoking. And again, the effect was more prevalent in males than it was in females. The secondary endpoint of longevity, the authors estimated that after the age of 40, over this 50-year period, we saw approximately a 7.8-year increase in life expectancy for men, of which 2.3 years of that increase was directly due to smoking cessation. 5.4 years of increase in life for women, of which 1.6 years was directly due to smoking cessation. The authors then estimated what they referred to as an ever-smoking prevalence, meaning at the age of 30, how many individuals in this country had ever used or smoked a cigarette. And what they found was that, again, significantly, the smoking cessation efforts resulted in a much lower rate of ever smokers. However, men were still higher than females in terms of this cigarette consumption. So they summarized that tobacco control has been a successful public health initiative. Approximately the 4.4 million lives that were saved under the age of 65, the authors correlated in socioeconomic terms to approximately $100 billion in terms of the savings of lost income or lost economic productivity from the population. There are some limitations to the study. These were estimates, so the smoking-related rates were based on several cancer prevention studies and population health surveys. They did not control or investigate smoking duration and intensity, which we know can impact the resulting health burden. However, they also stated that despite these efforts, there still continues to be approximately 20% of the U.S. population that continues to smoke, which will result, as these numbers show us, in an increased healthcare burden. So how does this relate to us as vascular surgeons? Well, we know that certain disease processes are related to ever smoking. And what this means, I think, in a lot of terms, is that when there are patients that are living longer with the initial insult of cigarettes at some point in their life, for example, specifically aortic aneurysms and peripheral vascular disease, one thing we should be prepared to expect is a higher prevalence and potential incidence of this disease process as these individuals continue to age. Furthermore, the population effect, I think, is significant, and the institution of public health programs resulting in improved survival cannot be understated. And these are population-based statistics, but I think it is important that we have quantitative numbers to estimate what the improvement in life is from smoking cessation. And again, this is powerful ammunition for us to continue patient counseling and risk factor modification. Thanks.
Thanks very much, and we'll move on to the next paper when Jenny Wong is going to talk to us about how peripheral vascular disease is being increasingly recognized as a global problem. Jenny?
Thank you very much, Greg. Good morning. I have no conflicts, disclosures. This paper was a systematic literature review of community-based prevalence studies published after 1997. And the authors identified PAD by an objectively and easily abstractable definition defined as an ABI less than or equal to 0.90. They used epidemiologic modeling and UN population statistics for years 2000 and 2010 to define age and sex-specific PAD prevalence. They did a meta-analysis of odds ratios associated with risk factors for PAD, and then uniquely made a comparison between high-income and low or middle-income countries as defined by World Bank statistics. This table demonstrates the 22 studies they used from high-income countries and 12 from low or middle-income countries. The prevalence of PAD increased with increasing age across all across all sex and income groups. For high-income countries, there was no appreciable sex difference between the prevalence of PAD in men and women. But for low and middle-income countries, there was a higher prevalence of PAD in women. This was up to the octogenarian groups, where then the prevalence leveled off and equaled that for men. Interestingly, by sex, for all men with PAD, the prevalence was higher in higher-income countries. By correlating prevalence rates with UN population statistics, the authors were able to demonstrate that there was a 23.5% increase in patients living with PAD over the 10-year period, from 164 million patients in 2000 to greater than 200 million patients in 2010. The older age groups experienced the highest rates of increase, with rates of 35 to 40% over the 10-year period. For low and middle income countries, shown in green, there was a higher increase over the 10-year period across all age groups when compared to higher income countries, shown in the column just to the left. By year 2000, it was estimated that more than two-thirds of patients living with PAD were concentrated in the low and middle income countries. Smoking and other cardiovascular disease were risk factors most strongly associated with PAD. Interestingly, from a global standpoint, male sex was correlated with a decreased risk of PAD. But when broken out by income groups, male sex was associated with a higher risk of PAD in high-income countries and a markedly lower risk in low and middle-income countries. In summary, this study is the first data-driven attempt to estimate global epidemiology of PAD, unquestionably a daunting task. The authors have made good use of the available data and have tried to take into account socioeconomic variability across the globe. They've demonstrated that PAD is a worldwide disease, with an increase of nearly 25% over the most recent 10-year period. And while PAD receives a lot of emphasis in higher income countries, they have shown an equal prevalence in low and middle income countries. In fact, the impact of symptomatic PAD may be greater in such countries where walking substantial different distances is required to obtain the necessities of daily life. And for the many asymptomatic patients across age and sex and income groups, the association between PAD, loss of mobility, functional decline, and cardiovascular events identifies PAD as a major global public health challenge. So what does this mean for vascular surgeons? Well, it means job security, because there will be plenty of work. It means we need to train qualified surgeons, increase the workforce, and be able to care for the increasing number of patients with PAD. This needs to happen here in the US and internationally. In addition, the scope of the problem has now been identified. This study should serve as the impetus for formulation of plans at all levels to increase public education and to move toward government and health agency action. This means we need more research. Research regarding the outcomes of preventive measures and treatments, medical, interventional, and surgical. And as leaders in the field, it means that vascular surgeons will need to be involved at the individual and the societal level in politics, political, and health advocacy activities to reach this goal. Thank you.
Thank you, Ginny. Next, we'll have Dr. Shanzer. Dr. Shanzer will tell us about what's becoming quite an obvious controversy about the use of beta blocker in non-cardiac surgery. Andres?
Thanks very much, and good morning. Thanks to be able to be part of this program. So in the way of background, as we heard yesterday during 2 plenary presentations, European and American guideline documents currently recommend perioperative initiation of beta blockers for intermediate or high-risk patients undergoing non-cardiac surgery. But we also heard that this recommendation is based primarily on the decreased family of randomized studies, which have now been discredited. Decrease 6 had fictitious methods and fictitious database. Decrease 5 was shown to have a fictitious adjudication committee. Decrease 4 was shown to have fictitious events that did not match primary outcomes. Decrease 3, there was no source data that could be produced from the study. And decrease 2 had fictitious outcomes. So the present study goal was to conduct a meta-analysis of randomized controlled trials of beta blockade on perioperative mortality, MI, stroke, and hypotension in non-cardiac surgery using what they refer to as secure data, that is, excluding the decreased family of studies. They included published randomized controlled trials comparing initiation of beta blockers prior to surgery versus placebo. They used fairly standard meta-analysis techniques to start off with approximately 300 studies. They whittled that down to 11 relevant studies, and then ultimately decreased that to 9 studies because 2 of them were associated with decreased studies. Their primary endpoint was perioperative mortality, and their secondary endpoints were MI, stroke, and hypotension. So going to the results, when they looked at perioperative mortality, they saw that beta blockade conferred a disadvantage with a risk ratio of death of 1.27. When they looked at MI, they again showed in this case that there was a risk ratio of 0.73, that is, beta blockade provided an advantage for MI. But when they looked at stroke, there was a risk ratio of 1.73, beta blockade again conferring a disadvantage. And similarly, when they looked at hypotension requiring chemical treatment, they found that beta blockade conferred a disadvantage with a risk ratio of 1.51. So their conclusion is that perioperative initiation of beta blockers increases perioperative mortality by 27%. They go on to state that guidelines for perioperative beta blocker initiation should be retracted. There are some limitations to this study. The meta-analysis as performed is dominated by the POISE trial. As most of you know, that included patients that had 100 milligrams extended release metoprolol administered 2 to 4 hours prior to surgery, which is generally considered to be a relatively large dose given in the immediate pre-surgery period, which could have led to some of the negative events. The secondary endpoints available that they looked at were only available in 5 of the identified studies, so they lose some of the power for their meta-analysis. And perhaps most importantly, there was no ability to stratify patients and try to identify whether there may be high-risk subgroups that do have some benefit. So what's the takeaway with this paper? For me, it's that if planning on vascular surgery and the patient is on a beta blocker, I believe it makes sense to leave him or her on that beta blocker. However, if planning on vascular surgery and the patient is not on a beta blocker, don't initiate a beta blocker. And then certainly most importantly, never falsify data. Thanks very much for the opportunity to be part of this program.
Thank you, Andres. Next, we'll consider on in a little bit of the medical theme here, and Dr. Baxter is going to talk to us about potential medical treatment of abdominal aortic aneurysms. As many of you know, Tim is leading this effort in the U.S. So, Tim, thank you.
Good morning, and thank you very much, Greg, for including me in this session. The paper I'm discussing today was published this last December in the Annals of Internal Medicine. The primary author was Jan Lindemann, who's an investigator from Holland. The study was done in Holland. And the first author is Dr. Meyer, who was the person who did all of the ultrasound studies for this. The methods for this paper was prospective, blinded, one-to-one randomization for doxycycline, 100 milligrams. It was done at 14 sites. The enrollment criteria were 3.5 to 5 centimeter AAAs, but unfortunately they also included a group of patients with larger aneurysms who were unfit for repair, so it was kind of a mixed group of patients. The primary outcome was looking at the growth in the AP diameter at 18 months. By ultrasound. The ultrasounds were done every 6 months by one physician. The primary measurement was the internal measurement done in the AP diameter. The analysis was done by a linear mixed model. And this was not an intention to treat analysis. It wasn't set up so that they could analyze the data in what we would consider to be the standard way to do that. Figure 1 here shows the flow of patients in the study. 690 were evaluated, approximately 140 randomized to each group. During the follow-up period, they lost between 25 and 30% of the patients in each group. And when the patients either went off drug or were lost in some way to the study, they were not included. They were censored from the analysis again, so it wasn't an intent to treat analysis. The patients were fairly well matched with regard to their characteristics, with really only one thing being a little unusual, and that was that 15 patients in these of the large aneurysms got into the doxycycline group, and only 9 got into the placebo group because they weren't stratified for that particular group. This shows the loss of patients over the course of the trial to surgery. The reason this occurred is that the patients were not managed primarily by this group, so when the vascular surgeons obtained a CT scan, the diameter was often larger because they were only looking at the AP diameter using the inner wall, and the patients would cross over to surgery, and they essentially had no control of that. And again, the patients were censored once they crossed over to surgery. When we look at the patients that were followed out to the 18-month time period on the bottom, we can see that about 2/3 of the patients made it to that 18-month time point, which means about 1/3 of the patients were lost during that follow-up period. The conclusion of this trial was that at 18 months, doxycycline did not reduce aneurysm growth and nor influence the need for aneurysm repair. The growth curves are shown below. There's an interesting trend in the bottom that suggests that the doxycycline group may grow perhaps a little bit faster. As some of you may know, there is a trial being conducted by vascular surgeons from this society in the US now. This trial is similar in terms of number of patients planned for enrollment. We're currently at about 1/3 of our enrollment. The doxycycline dose is different at 200 milligrams, which I'll show you we think is quite important. The primary endpoint is 24 months rather than 18. The intent to treat analysis is what will be done. The primary imaging is CT, which we also think is quite important. And then we have a series of biomarkers which will be obtained every 6 months. And we're also going to do drug levels, which is important if you have a negative trial in these patients. These are some early studies that were done by our group and Dr. Thompson's group, and one of the things we found out in a mouse model of aneurysms is that there is a threshold where that you have to reach to get a good effect, and it's shown in this oval here. And then we also studied aneurysm patients, which is shown on the right, your left, and what that shows is that when we gave patients 200 milligrams a day of doxycycline, we could get their levels up to about 4 micrograms per mil, which is really what the level where we think these patients need to be in order to get the inhibitory effect of the drug. And we couldn't achieve that with the lower dose that was used in the trial. Another important piece of work that was done by John Kirchie, Rob Thompson, showing pre-treatment of patients undergoing surgery with doxycycline at 200 milligrams significantly reduced the MMPs, which is the main basis for this study. The central CT imaging is really an important part of our trial. All of the CT scans are sent to John Matsumora's group. They're analyzed by one person. They use a double oblique method. As you can imagine with ultrasound, it's difficult to get these kind of measurements precisely. There's issues of patient size, reproducibility, and then in that study there were crossover to surgery because the CT results were often larger than the ultrasound, and we would avoid that problem in this study. So in conclusion, does FAST, the study that was just presented and done in Holland, add to our current knowledge of medical therapy for AAA? And certainly it does. Is it a definitive trial? It's definitely not. NTACT will, when it's completed, have 1,250 CT scans done at 6-month intervals and 1,250 blood draws with biomarkers on 250 patients. This will provide the best natural history data ever obtained for abdominal aortic aneurysms. It will help us extensively to understand the biology of aneurysms, whether drug therapy works or not. Thank you very much.
Thank you, Tim. Tim, we certainly appreciate your efforts and steadfast efforts over the years in this field. And next talk will be by Dr. Elliot Chaikoff, I'm sure all of you know. And he's going to talk to us about surveillance intervals for small abdominal aortic aneurysms. And as I'm sure everyone realizes, Dr. Chaikoff was the primary author of the guidelines for management of abdominal aortic aneurysms, and perhaps has a bit of a conflict then, since it may be a bit different. Anyway, Elliot, go ahead.
cognitive bias. So this paper was published in JAMA in 2013, and the lead PI was Simon Thompson, who's part of the epidemiology unit at the University of Cambridge. The other investigators came largely from public health and epidemiology groups from across the UK. Janet Powell from the vascular surgery program at Imperial College was also part of the ReScan collaborators. This was a meta-analysis of some 18 studies that were published during a period from 1998 to 2012. The study cohort included some 15,000 patients. 90% were male, and the mean follow-up among these 18 studies ranged from 1 to 8 years. The meta-analysis revealed that the time for a patient to achieve a 10% risk of exceeding an aortic diameter of 5.4 centimeters was very dependent upon the initial aneurysm diameter. At 3 centimeters, that time interval was 7.4 years. At 4 centimeters, 3.2 years. And at 5 centimeters, 8 months. The mean aneurysm growth rate was 1.3 millimeters per year for those patients who had an initial aortic diameter of 3 centimeters and 3.6 millimeters a year for those patients with an aortic diameter of 5 centimeters. Very similar results were found when examining the time to reach a 1% risk of aneurysm rupture. For those patients with a 3 centimeter aortic diameter, that time interval was 8.5 years. At 4 centimeters, 3.5 years. And at 5 centimeters, 1.4 years. Importantly, the authors highlighted the shorter time interval for women. For those women with an aortic diameter of 3 centimeters, the time interval was 3.5 years. With an aortic diameter of 4 centimeters, the time interval was 1.4 years. And for those with an aortic diameter of 5 centimeters, the time interval was 8 months. The authors highlighted that there was a significant degree of study heterogeneity among these 18 studies that comprised the meta-analysis, whether one was examining the time interval to reach a 10% probability of aortic diameter exceeding the 5.4 centimeter threshold, or time to exceed a 1% risk of rupture. And much of this heterogeneity among the studies could not be explained. But they did highlight that there was a fourfold higher rupture rate for women compared to men. The study also highlighted the significant degree of heterogeneity from one country to the next with regards to surveillance intervals for patients presenting with an aortic diameter. In Denmark, the interval for surveillance that's been recommended is 12 months. In the UK, for patients with aneurysms between 3 and 4.4 centimeters, the ultrasound surveillance interval is 1 year, and for those with aneurysms between 4.5 and 5.4, it is 3 months. And the SVS guidelines, which I happen to serve as chair of the study committee, has guidelines that recommend a 6-month surveillance interval for patients who have an aneurysm between 4.5 and 5.4, 1 year for those who are between 3.5 and 4.4, and longer time intervals for smaller aneurysms. So the authors of this study recommended a different set of surveillance intervals with 3 ranges of aneurysm diameters. For those patients in the 3 centimeter range, 24 months, in the 4 centimeter range, 12 months, and for those between 5 to 5.4 centimeters, 6 months. I do believe the authors highlight the importance variability between surveillance intervals and the lack of a sound and strong rationale for choosing an optimal interval. Clearly, there are multiple factors in play, including economics, patient anxiety, and ultimately reducing the risk of rupture. If anything, this study highlights an important opportunity for the VQI or other clinical trials initiatives to address this important question. I'd like to thank the program committee again for the opportunity to present.
Thank you very much, Elliot. We're going to take a few minutes now to discuss this first set of papers, and people, please go to the microphones if you have a question. I'll start off. I'd like to ask, based on the Surgeon General's report and its impact, And you alluded to this a little bit about what we as a society can do for all of this. Our emphasis has been on treatment, and many of the other societies have had emphasis also on prevention. Do we need to move more in that direction as a group?
Sure, I think that's absolutely the answer. But the other thing I think is important is as we make those efforts, it's oftentimes daunting for the resources that are required, but I think the paper does really provide us good results so that we can justify a lot of the large population-based efforts. But definitely prevention is more effective than treatment.
Rebeth, you have a
question for Dr. Chekhov. So based on this paper, when you update the 1999 guidelines, are you going to change the surveillance recommendations?
That was a question that Dr. Mineta asked before I came up, and I'm not sure I would. Again, no, it is all somewhat qualitative, and there are some limitations certainly to any meta-analysis, which is certainly not a definitive report. I certainly feel, at least in my own practice at this point, if a patient comes to me with an aortic aneurysm that's 4.8 centimeters, I would prefer to see them at 6-month intervals. So unless additional information comes to light, I think for patients in the 4.5 to 5.4 centimeter range, a twice-yearly ultrasound exam, I think is reasonable. That may not be, I guess, an evidence-based definitive statement, and so we'll wait to see, but that was my gut feeling in reading the JAMA report.
So can I ask Elliot, what techniques for measurement of with ultrasound should we use?
I'm not sure. I'm probably best positioned to answer that. Why don't you...
I mean, it seems like there have been various ones used in all the different trials. Inner to inner wall, outer to inner wall, those.
Yeah, I would say, from my perspective, outer wall to outer wall, but I would defer to those who have correlated this with CT imaging.
Yeah. Tim, did you have any thoughts on that? Since you must have thought about this when you designed your trial pretty heavily.
I think one of the things that was interesting in the Dutch trial was they used inner wall diameters, and of course that undersized the aneurysms compared to CT. So there is a difference in CT measurements, and they typically are larger. One of the things we see is this rapid growth phenomenon, and the rapid growth is usually not real. It's usually related to comparing a CT and an ultrasound. So when you compare those two different studies. So I think with ultrasound, looking at outer wall to outer wall is more likely, gives you a better correlation with what you're going to see with CT scan. But no matter how you do that, there's still going to be a difference. And again, in the ATOM trial, where there were 500 CTs, patients weren't having rapid growth because they were comparing CT to CT to look at the measurements. And so most of the time in our clinical practice, when we see that, we're either looking at a radiology report that said one thing and then we're comparing it to what we're getting, or we're comparing ultrasound and CT. So I think probably the outer wall diameter may be better.
Dr. Rai?
Yeah, Kumud Rai from India. The question is to Virginia Wong. In the paper, it states that the women have a much higher incidence of PAD compared to men, which is against what we have known so far, and also my personal experience in India for the last 20 years. I think there was a paper from India as well. So any explanation why this has undergone a dramatic change? Do the authors say anything about it?
That's a very good observation, and was one of the surprising factors I think I noticed in that study as well, and that was certainly what they found, particularly in the lower and middle income countries. One of the proposed mechanisms for that is the possibility that with increased cardiovascular death rates among men in those countries, women are actually living long enough to develop PAD, and that might have affected some of the PAD prevalence numbers in those countries. Other than that, the retrospective review nature of the study and the way they included or excluded articles really doesn't allow a good answer to that question.
Thank you.
Dr. Zolak?
Hi, good morning. I have a question for Dr. Schanzer about the beta blockers. So when many of us return to our day jobs on Monday, we'll face expectations that almost every patient going to the OR should be on beta blockers for skip measures, and certainly at the VA, every patient's supposed to be on beta blockers. So do the current findings contradict the current recommendations of the skip measures? And if so, is anybody doing anything about that?
Thanks, Dr. Zwolak. You know, I believe these findings do contradict those studies. And interestingly, as I think you saw presented by Sal Scala yesterday, we've tried to look at this sort of up and down through the VQI, looking at select subsets, looking at high-risk populations. And while given the limitations of the VQI, we were unable to show any population that uniformly benefited from pre-op beta blockade. In addition, there was another single-center study that was presented yesterday with the same findings for non-cardiac vascular surgery. So I think we're put in a tough position right now. As I think you recall, the VSG&E as well as the VQI use beta blocker use as a quality measure, and that has now been retracted because of some of these findings. But I think that that body of evidence is really called into question.
Dr. Bajort?
I just wanted to make a short comment to the discussion on ultrasound measurement. We recently published a paper in the British Journal of Surgery where we compared the outer to outer, the inner to inner, with the leading edge to leading edge methodology. And the method with least variability is actually the leading edge to leading edge, which is in terms of physics, the most accurate method to measure abdominal aortic aneurysms. So maybe you have some comment on that?
No, it sounds like an important opportunity to really establish a standard, and we'll look forward to reviewing your paper in greater detail.
Thank you very much. I want to thank all the discussants. We need to move forward and stay on time. I think in the interest of that, I'm just going to ask Dr. Wong to come back up and start her presentation. We'll skip the part on non-selected papers and move right into Dr. Wong's discussion of, yeah, you can go. Of renal artery stenting. Jenny, go ahead.
Thank you. So obviously I'm not Dr. Kashyap, who sends his regards and his apologies for not being here today. There are no disclosures. So the cardiovascular outcomes in renal atherosclerotic lesions trial, or CORAL trial, as you know, is a multi-center randomized prospective trial that was published in New England Journal of Medicine in November 2013. The study had 947 patients with renal artery stenosis randomized to renal stenting with medical therapy versus medical therapy alone. And patients were eligible if they had systolic hypertension and were on at least 2 antihypertensive medications, or if they had chronic kidney disease stage 3 or higher. This trial is distinguished by the dictation of medical therapy in both groups. Unless there were specific contraindications, patients were on candesartan with or without the addition of hydrochlorothiazide, and the combination drug that includes amlodipine and atorvastatin. Medication doses were up-titrated to preset targets of less than 140/80 for patients without comorbid conditions, and a lesser target was set for patients with diabetes or CKD. Over a median follow-up period of 43 months, the primary endpoint was a composite of cardiovascular and renal death, MI, stroke, hospitalization for congestive heart failure, progressive renal failure, or the need for renal replacement therapy. This was a nationally funded study. The bottom line is summarized in this Kaplan-Meier depiction, where the primary endpoint did not differ, with equal rates of composite events in both treatment groups. In addition, there was no difference detected between the treatment groups when looking at the components of the composite endpoint, such as that for progressive renal failure, as shown on the very bottom of the slide. With regard to hypertension, at baseline, patients were on an average of 2.1 antihypertensive medications. And as the study mandated up titration of doses to reach the preset target blood pressures, medications increased in both the stent group and the medical therapy only group to more than 3 medications per patient. They did observe a modest decrease in systolic blood pressure among the patients who were stented, less 2.3 millimeters mercury when compared to the medical therapy only patients. This difference was statistically significant. These results led the authors to conclude that renal artery stenting did not provide additional benefit to medical therapy alone in patients with renal artery stenosis. However, as we've all realized thus far, there were several limitations to this study. Of over 5,000 patients with renal artery stenosis who were screened for randomization, more than 1,000 declined to participate, were withdrawn by their physicians, or were otherwise not randomized. This study allowed patients in who had hypertension or chronic renal failure, such that 30% of patients in both groups already had a blood pressure at target. 50% had normal renal function or near normal renal function at baseline. And 20% or fewer in each group had global renal ischemia, as defined by greater than 60% stenosis in all renal arteries to both kidneys, or all arterial supply to a single functioning kidney. In addition, the degree of angiographic renal artery stenosis, as confirmed on core laboratory measurement, was only about 68%. And these factors may have limited this study's ability to detect an additional difference with stenting, particularly with regard to hypertension and renal failure during the follow-up period. In summary, compared to the past studies, CORAL is a better designed trial, and there is some compelling data, but it is still one that demonstrates there is no additional benefit with stenting in patients with renal artery stenosis compared to medical therapy alone. What CORAL does show is that modern medical therapy is effective, particularly for the type of patients who were randomized in this study. But as I've mentioned, it was a fairly selective patient group. And those of you who were here for the debate yesterday witnessed Dr. Corrier's very extensive review of this article, and by the end of that session, a majority of us, 84% in the room, still believed that there may be a role for renal artery stenting in certain patients and in certain clinical conditions. Still, I think we must concede that the CORAL trial may represent the final nail in the coffin for widespread renal artery stenting. Thank you.
Thank you very much, Jenny. Next paper will focus on the use of endografts in treatment of type B dissection by Dr. Zach Arthur from San Antonio. Zach?
Thanks, Greg. I have no disclosures. I want to thank the program committee for the opportunity to present the INSTEAD XL trial. This represents an amendment to the protocol to extend the trial beyond 2 years and provide the 5-year follow-up for the INSTEAD trial. It's important to note that this is a multi-center trial across 7 European centers. It is a randomized controlled trial designed to treat uncomplicated subacute type B dissections defined as greater than 14 days from the initial event. They are randomized to optical medical therapy compared to optical medical therapy with thoracic stent graft. Their treatment design used the Medtronic Talent device with a goal of primary entry coverage. The average cover length in this trial was 18 centimeters of the thoracic aorta with or without subclavian coverage. It's important to note, and maybe the most important aspect of this trial is to look at the excluded population. 597 patients were screened, 23% of which were included, which resulted in 140 patients. They excluded patients with a thoracic dissected diameter of greater than 5.5 centimeters, if they were in an acute presentation of their disease, if they had any component of rupture or malperfusion. When you looked at the 2 treatment groups, there are really no measurable or demonstrable differences between those groups. There was an average dissected diameter at the time of enrollment of 45 millimeters. 90% had a thoraco-abdominal extent of their dissection, and the average time to treatment and randomization was 45 days, with the earliest being 18 days. The primary endpoint of the trial was all-cause mortality, which was not met. The mortality in this group with optimal medical therapy was 19% at 5 years, compared to 11% in the optical medical therapy with the TVAR group. However, if you can look, there's clearly a trend, and it looks like there's a disparate trend somewhere in the 2 to 3 year mark, and that was the focus for the remainder of the manuscript. It's most important to look at the tabular data of the deaths that occurred, and if you look in the first 2 years, there's a disparate number of deaths in the optical medical therapy with TVAR group, but there are non-aortic deaths which really shift the weight of this in the fact that there are 3 deaths unrelated to their dissection. In the optical medical therapy group, there were 3 patients that either ruptured or had a malperfusion syndrome. Most remarkably, outside of 24 months, there were no deaths in the patients that received medical therapy with TVAR. However, there were still aortic-related deaths in the medical therapy group. So if we exclude the patients that died due to an unrelated aortic event, now we have a statistical significance. The best medical therapy arm remains at 19% at 5 years. However, our mortality in the treatment group now drops to 6.9 or 7%, and we now have a significant difference within the trial. It is important to look at the crossovers. With optical medical therapy, 29% of those 63 patients eventually met those exclusion criteria, which was mainly a diameter measurement, and crossed over to TVAR or open repair. Within the TVAR group, 10% required an additional extension of their TVAR, and 4% required open repairs. Of note, of all the crossovers and all the patients that converted to open repair, there were no deaths related to those events. There were morphologic trends associated with TVAR for subacute type B dissection, which we have observed in our retrospective trials as well. Overall, there was a reduction in the maximum aortic diameter. Proximal and distal true lumen expansion was visualized over time, and there was positive false lumen remodeling, mainly in the ways of thrombosis. Overall, in this trial, the optical medical therapy arm was much better than was anticipated with their power analysis. For their power analysis, they used a 30% all-cause mortality at 2 years, not 5 years. This trial had an all-cause mortality of 19%, which was much better than anticipated. It can be explained by the trial effect. They had a 90% compliance, which is markedly better than is what is typically reported in the community. There was close surveillance with imaging, and most importantly, there was the crossover option to receive stent graft therapy or open therapy. The benefit of TVAR in this trial only emerged after 2 years of survival. It did not impact the all-cause mortality, but clearly reduced the aortic-related events. Of those patients that crossed over, there was also a correlation with the actual size of the entry tear being greater than 10 millimeters. So in conclusion, the all-cause mortality was not significant over the follow-up of 5 years. The TVAR reduced aortic events did result in a reduction in the aortic mortality over this time, but it was only after excluding those patients that were randomized that died of other causes. Optical medical therapy's performance was much better than anticipated, and this is likely related to the option of the selection criteria to cross those patients over to the treatment arm. Thank you.
Thank you, Zach. Now can Dr. Matt Eagleton from Cleveland is going to talk to us about 2 trials on treatment of ruptured abdominal aortic aneurysms with endografts.
Thank you. And I'm going to discuss 2 different trials. The first trial is on behalf of the Amsterdam Acute Aneurysm Trial collaborators, and it's called Endovascular Repair versus Open Repair of Ruptured Abdominal Aortic Aneurysms, a multi-center randomized controlled trial. These are the disclosures I have that I'm willing to admit to now, but by the end of the program, I'm going to admit to another disclosure, but I'm going to hold off and you'll see why. What's the hypothesis of this trial is that EVAR would reduce mortality and severe complications when compared with open surgery for treating ruptured abdominal aortic aneurysms. And when we look at these trials, we have to look at how the trial is constructed and how patients are selected, because I think it does influence our outcomes. The methods for this trial, it was a regional, randomized, multi-center trial across Greater Amsterdam. It included 3 treating centers and 7 referral centers that would send patients to those 3 referral centers. There are anatomic criteria for enrollment, which included a 10 to 15 millimeter infrarenal neck, an infrarenal diameter of 20 to 32 millimeters, iliac length and neck diameters as well on both sides. Their EVAR approach to this was standardized across the trial. And they used an aortouniiliac device, 2 devices that changed over time, with a contralateral iliac occluder and a femoral bypass. So perhaps not the choice of approach that would be standardly taken at many centers. The primary endpoints that they evaluated in this trial were a composite of death and severe complications at 30 days. Excuse me. They had 520 patients during this time period present with a ruptured abdominal aortic aneurysm. Of those, only 29% were found to have favorable anatomy for enrollment in the trial. Of these, only 116 patients were randomized for treatment. Of these, 59 were assigned to open surgical repair, 57 were assigned to endovascular repair. Of the 57 that were assigned to endovascular repair, almost immediately 2 were transferred over to the open arm. They weren't transferred to the open arm, but were converted to open surgery, one because of a sudden cardiac arrest, and the second because an endovascular stent graft was not available. So 62 were started in the open arm, 55 were started in the EVAR. Of these, 63 completed open repair, where only 46 completed endovascular repair. Well, why? 3 in the open arm were found not to have a ruptured abdominal aortic aneurysm, and there were 4 perioperative deaths. In the EVAR arm, there was 1 perioperative death, but there were 8 that were converted to open surgery during the perioperative time. 3 of these were due to poor iliac access, they couldn't get the device in, and 5 were due to a persistent endoleak and continued bleeding from the ruptured aneurysm. Well, how did they do? Excuse me. The demographics between the 2 groups was actually quite similar, except for time to surgery. It was a slower time for surgery in those that were undergoing endovascular repair, and those patients that underwent open repair potentially were a bit sicker in that they had a lower pH and a lower bicarbonate. The primary endpoints in these were on an intent to treat basis. Those that were randomized to the EVAR group had a 42% primary composite endpoint of mortality and severe complications. And that was 47% in the open aneurysm repair group. If we look at specifically at mortality, it didn't vary between the 2 groups of 21 and 25%, and severe complications was the same at 32 and 37%. The only difference between the 2 groups is there is a higher incidence of renal insufficiency in those undergoing open repair. If we look at secondary endpoints, more patients undergoing open repair were admitted to the ICU. They had a higher requirement for ventilatory support. They had a higher hospital stay, but they had a shorter duration of surgery. It took longer to do the endovascular repair. There was a higher mean blood loss in the patients undergoing open repair and a higher amount of autologous blood transfusion. There were 10 patients in the EVAR arm that required blood transfusion, but all of these had crossed over into open surgery. In conclusion, they conclude that no differences in combined death or severe complications for open versus EVAR for ruptured abdominal aortic aneurysms based on intent to treat. 15% of the population, though, didn't get a CAT scan due to hemodynamic instability and were excluded from enrollment in the trial. 61% of those transferred and evaluated with CERTI were not anatomic candidates for EVAR, which shows some of the limitations of using an EVAR for treatment of ruptured abdominal aortic aneurysms, and weren't candidates for the endovascular approach they prescribed for the study, but perhaps given a more liberal application of endovascular therapy, may have been candidates. There was an intraoperative conversion rate to open repair from EVAR in approximately 14% of the patients, 8 patients. There were 6 additional patients that were converted to surgery postoperatively due to the presence of a type 1 endoleak. These 14 were largely responsible for the proportion of deaths in the EVAR arm. There were 39 with favorable anatomy that were excluded, and if we look at those patients that were excluded with favorable anatomy, the mortality rate in the EVAR, those that ultimately underwent EVAR, was 17%, and it was 42% in those that ultimately underwent open repair. Excuse me. I'll move right into the second paper, which also is a randomized prospective trial to look at endovascular repair of ruptured abdominal aortic aneurysms. And this is from the improved trial investigators reporting their 30-day outcomes. Again, a randomized prospective trial. Interestingly to see these back to back. Again, my disclosures. The hypothesis in this trial is that a strategy of endovascular repair, if anatomically feasible, reduces the 30-day mortality of patients with a clinical diagnosis of ruptured abdominal aortic aneurysm compared with treatment by open repair. Patients in this trial randomized a bit differently. They were randomized to one of 2 arms. Excuse me. All right. The endovascular strategy arm, if they were randomized to that, and these were patients with suspected clinical diagnosis of ruptured abdominal aortic aneurysm, they were randomized to either an immediate CT scan with emergent endovascular repair if they were anatomic candidates, and open repair if they were not anatomic candidates. And that entire cohort is considered the endovascular arm. The second arm they were randomized to was a standard approach with open repair. There were 29 centers in the United Kingdom and 1 in Canada for this trial. At least 20, to become an enroller, you had to have performed at least 20 endovascular repairs per year and have had at least 50 aortic cases per year at your center. You were excluded if you had a prior aneurysm repair, if you had a rupture of an isolated internal iliac artery aneurysm, if you had evidence of an aortocavo or an aortomesenteric fistula, if you had a recent anatomic assessment. For example, you'd already been approved to have an endovascular repair and you were waiting to get your repair. If you had a known connective tissue disorder, or if the indication for repair of the intervention was considered futile. Excuse me. Primary endpoints for this study were survival at 30 days. There were a number of secondary endpoints that they hoped to look at, including 24-hour mortality, in-hospital mortality, cost of primary admission, re-interventions during the primary admission, and time and place to which the discharge from the trial hospital. Here's the consort diagram looking at how patients were stratified into the two groups. A little hard to read, so let me break it out for you. There were about 1,275 patients that presented with a ruptured abdominal aortic aneurysm, clinically suspicious for rupture. Of these, 49% of the patients were randomized into the study. 613 patients were analyzed. They had a small subset of patients that once the outcomes board evaluated them, they didn't meet inclusion criteria and were excluded from further analysis. Of these, 316 underwent an EVAR strategy and 297 underwent an open operative strategy. Of those that underwent an EVAR strategy, 150 of those actually underwent endovascular repair. They are found to be anatomic candidates for that. There were 4 patients that were stratified to undergo EVAR but were converted to open repair during that time. There were 112 that underwent actual open repair. There were 17 that did not get a repair at all. And there were 33 patients, or 10%, that were found to have a diagnosis other than ruptured abdominal aortic aneurysm when they underwent their CT scan. If we look at the open arm, 36 patients in this arm ultimately underwent endovascular repair. 220 went open repair. 19 of these patients underwent no repair, and 22, or about 7%, same as the other arm, were found to have a diagnosis alternate to ruptured abdominal aortic aneurysm. If we look at the 30-day mortality on a basis of intention to treat, the 30-day mortality in the endovascular arm was 35%. In the open arm, it was 37%, with no significant difference. Not listed in here, but one of the breakouts of this, if we look at those that might affect outcome, women tended to favor better if they were in the endovascular arm, with lower mortality rates than if they were in the open arm. One of the unique findings of this was the disposition to home. If we look at the number of patients that were discharged directly to home, there's a significant improvement in those that were randomized to the endovascular arm, with 94% of them being discharged directly to home within 30 days, where only 77% of those that underwent open surgery were discharged directly to home. But and here's where my other conflict comes in. I've listened to a talk by Dr. Frank Veith, and I don't know if he's in the audience today, but he gave a talk on why I shouldn't listen to a randomized prospective trials and that they're all flawed, and that I should ignore all the results and just take from them what I think the take-home message should be. And I heard him give a talk about this trial earlier today and some arguments going back and forth. And this is sort of the argument as to why they think, or he thinks, or some other people may think, that endovascular therapy may indeed be better than open therapy based on this trial. If we look at the patients that actually underwent endovascular therapy, 150 got an EVAR. Those patients specifically had a 25% 30-day mortality. Of those that underwent open repair, 38% of those that actually underwent open repair had an operative mortality. And so that's a difference between those two groups. If you actually got an endovascular repair, you had a lower mortality rate. What if we look at the open arm? 220 got open repair with a 37% operative mortality rate. If we look at those that actually got an EVAR in that arm, the mortality rate drops to about 22%. This could suggest that those patients who actually get endovascular therapy may have a lower 30-day operative mortality rate. In conclusion, there's no difference in 30-day mortality rate based on cohort stratification and intent to treat. But only 40% of those assigned to the endovascular arm actually received an endovascular therapy. There was a 10% crossover in addition to that. Survival based on procedure favors EVAR at 25% versus 38%. And there was a conversion from, in this series, conversion from endovascular therapy to open therapy was almost always fatal, and it suggests that we need to carefully select patients for endovascular therapy, and if they're not candidates, they should get open repair. Thank you.
Thanks very much, Matt. Final paper will be discussion of the use of oral anticoagulants in the treatment of venous thromboembolism by Dr. Wu from USC.
Thank you, Dr. Mineta. I have nothing to disclose. Apixaban, which you may also know by its trade name Eliquis, is an oral factor Xa inhibitor that has predictable pharmacokinetics and allows for a fixed dose regimen and does not require any monitoring. It is currently FDA approved for prophylaxis in patients with non-valvular atrial fibrillation and after hip and knee replacement. In their previous study, they showed that apixaban was effective for the prevention of recurrent venous thromboembolism in patients who had already undergone 6 to 12 months of traditional therapy with similar rates of major bleeding compared to placebo. In this trial, the AMPLIFY trial, or apixaban for the initial management of pulmonary embolism and deep vein thrombosis as first-line therapy, it was a randomized double-blind trial comparing apixaban versus enoxaparin and warfarin in patients with objectively confirmed symptomatic proximal deep vein thrombosis or pulmonary embolism over 6 months of treatment. Of note, this was a study that was sponsored by Bristol Myers Squibb and Pfizer, and the steering committee was made up of Pfizer employees. Their primary efficacy outcome was composite recurrent symptomatic VTE or death related to VTE. The primary safety outcome was major bleeding, which was defined as overt or associated with a decrease in hemoglobin of 2 or more, or required a transfusion of 2 or more units of blood, or occurred into a critical site or contributed to death. Their hypothesis was that apixaban would be non-inferior to conventional therapy with respect to primary efficacy outcome. In terms of their statistical analysis, for the efficacy analysis, they performed an intent to treat analysis, and for the safety analysis, they used the actual study treatment data. In the apixaban group, they were assigned to take 10 milligrams of apixaban twice daily for the first 7 days, followed by 5 milligrams twice daily for 6 months. They were also given placebo enoxaparin injections and placebo warfarin tablets. In the conventional therapy group, these patients received enoxaparin 1 milligram per kilo every 12 hours for 5 days, at least 5 days, and they also had their warfarin continued for 6 months, and they also received placebo apixaban tablets. Everybody underwent blinded monthly INR monitoring, at least monthly INR monitoring, with a sophisticated encryption result. So a total of 5,400 patients underwent randomization. 2,691 were assigned to receive apixaban, and 2,676 of those were included in the safety analysis. 2,704 were assigned to receive conventional therapy, of which 2,689 were included in the safety analysis. The age of the patients was approximately 57 in both groups. There was slightly more males in both groups, and the qualifying diagnosis was DVT for the majority in both groups. So the incidence of VTE or VTE-related death was 2.3% in the apixaban group and 2.7% in the conventional therapy group, for a P of less than 0.001 for non-inferiority for apixaban. In terms of major bleeding, this occurred in 0.6% in the apixaban group and 1.8% in the conventional therapy group, for a highly significant p-value for superiority for apixaban. So this was a randomized double-blind trial, which I felt was very well designed. It was adequately powered. They even increased the number of patients after approximately, after 80% of the patients were enrolled due to patients stopping the drug early. And although this was an industry-sponsored trial, the qualifying diagnosis as well as the outcomes were adjudicated by a blinded committee. The only thing was that there were several populations that were excluded. Patients who had distal DVT only, patients who underwent a thrombectomy or insertion of an IVC filter, or patients who had already received 36 hours of treatment with heparin or low molecular weight heparin were excluded. And so it's unclear if the results are applicable to these patient populations. However, their conclusion was that apixaban is a simple, effective, and safe regimen for the initial and long-term treatment of venous thromboembolism, which I agree with and I believe can probably be safely extrapolated to those populations that were excluded. Thank you.
Thank you very much, Karen.